Welcome everyone. Welcome everyone to this new lecture series on allergy and asthma. And we have today with us a very eminent speaker, Professor P.K. Vedanthan from University of Colorado, Denver, who's also running a global service on allergy and asthma and runs several courses in India about teaching of this specialty to doctors and residents. He's also a visiting professor to CMC Vellore, and he's currently a visiting professor to PGI Chandigarh. And recently I came across a book which has been written about P.K. Vedanthan. And I think we will be talking about that later in one of the sessions. So Professor Vedanthan, today you're going to be speaking about allergy and asthma status in India. Please, I welcome you to this session.
Thank you, Professor Meenu Singh. Thank you very much for the kind introduction. So I will go ahead and start the talk, and let me share the screen. I'm very happy to be associated with PGI Chandigarh, and thank you for inviting me as a visiting professor. Thank you. I appreciate it. Let me get this. Okay. So thank you for the kind introduction. So the topic today is an important topic. It pertains to all of us. And we are going to address the issue of what is the status of allergy and asthma in India? What are the challenges? What are the issues? How was it before? How is it now? How it could be in the future? And some of the opportunities we have, some of the obstacles we have. So I'm going to just touch upon all those different issues. So before I go to the specific topic, I just added this slide just today because I thought, maybe I should share some of the experience I had very briefly before I really got involved in this educational outreach. So I actually after graduation from Mysore Medical College in 69, I moved to US in 71. After my training, by that time, I was had finished fellowship in allergy immunology and had done pediatrics, 1 year of medicine. In 76, I came to India, visit my family, as well as visit my colleagues. And naturally, there was quite a bit of request for consults and all that by my friends or my relatives or neighbors like that. And I found there was not a single allergy specialist in South India. And I visited the place every year during that period for the next 10 years. I come to India every year because we had small children growing up. We wanted to have them exposure to the Indian environment and the culture. And I ended up doing consultations in the corridors, in the parties, in the casual gatherings like that. So to make it more organized, I started doing the first allergy asthma camp was held in Bangalore. And it was a very small ad in the local paper. And what it ended up was 400 patients showed up. It took us 3 days to clear up the crowd. So it really opened my eyes. And I came to realize there was a huge need for appropriate care and management of a very common and a significant problem in the society. And at that time, as I just told you, there was no specialist. So anyway, couple of us from US and a few people from Bangalore, we joined together, started the first allergy asthma clinic in Karnataka along with Rotary. It was a subsidized clinic. It ran okay for a while, and then it got converted into more like a chest and allergy. And the only training program at that time was a VP Chest Institute, like 1 or 2 week course was given. And we continued to do our work, doing several CME across the country, and doing these camps, increasing the awareness until 2006. The breakthrough was a partnership with the Christian Medical College, Vellore, when we first started the first formal training called Diploma Allergy and Asthma. Since then, it has been a continuous increase in these outreach activities across India and beyond. So what has happened to India during this last 50 years? It has changed a lot, and we know that. And you know that India is a huge country, but definitely huge in population for sure. It is 1/3 the size of USA, but 3 times more population. We have the most highly diversified population, not just by the way people look, but the way they eat, their habits, their living, activity, environment, genetics. It is one of the most diverse culture, and diversity of the foods, you know it. It is unbelievable. So there are 22 major languages, almost 700, maybe 700 dialects like that. So it's a very, very diverse environment. And the lifestyle varies from every 50 to 100 miles. It is different. And when you have such differences in lifestyle, and that changed a lot over the next 40, 50 years, the disease pattern has also changed. So this was the way India was when I grew up. A lot of bullock carts, very few cars, a lot of bicycles, some two-wheelers, a lot of open space, very little pollution. You could identify people by the car. You can say this so-and-so was going in the car, like that. But now it is entirely different. India is a different country. It is full of people, full of automobiles, full of color, and people have a lot more cash to spend, and economically much, much better off than at the time I left in the 70s. So this is a different India. So when you have a different India, what will be the different disease pattern? It is entirely different now. When we used to be in medical college and all that, it used to be when you entered the medical floor or the pediatric floor, you would see all these IVs running, people, mostly gastroenteritis. There was typhoid, there was some cholera, and all sorts of mostly bacterial infections. But nowadays it is lots of drips and nebulizations and a lot of cancer, a lot of diabetes, a lot of psychological problems. So obesity, metabolic syndrome, all these have evolved because of the change of lifestyle. And allergy and asthma is one of them for sure. So people now are eating more, sitting more, spending more, moving less, always wired, very, very disturbed sleep patterns because of the type of job people have now with the IT, and it's because of the globalization. All these things have changed, have influenced the diseases a lot. Now, what has happened in the allergy field? The allergy field in India is evolving quite rapidly. And what has happened is, although the prevalence of allergy in India is less, the severity of the cases is significantly high. Because of the low prevalence of allergy in India, a lot of interest is there. A lot of developed countries are interested in India to see why is allergy low in prevalence in India. But it is changing because we are trying to copy the industrialized world, and actually because of that and to several other reasons, the prevalence and the incidence of allergic diseases and asthma definitely has increased, but still lower than several other highly developed countries. For example, food allergy, the prevalence is true allergy is less than 1%, whereas in Australia, it is like very well proven studies shown by direct oral challenge, is about 10%. So there's a huge, still there's a lot of difference between developed countries and India. So there is a lot of interest in India to see why is it low? Is it because of the diet? Is it because something we are doing right or what? So that is why it's very important for us to start collecting data. We need to create our own data. We have been using all Western data, even for epidemiological studies and as well as for management and all that. So we need to create Indian data, and we are. So Indian data has definitely is coming out, and it's very, very important. And it is a low middle income country, population 1.3 billion. And as I told you, multiple factors are involved in environmental thing. And now, if you look at the Indian population, 70%, almost about 67 to 70% are below the age of 45 years. So it is a young country. So it is a young country, and it is a very crowded country. And if you look at the choice of asthma treatments across India, it is all over the place, from fish therapy to yoga therapy to Siddha to Ayurveda to homeopathy to inhalers to nebulizers. And we have now all the way, we have people on ventilators, we give all the biological. So we have like a whole spectrum of treatment, right from top to bottom. We have in India the difference between Indian medical scenario as well as and the other Western countries. Here it is additional things. The newer things are added on to the existing new old ones, and the old ones don't go away. They are not totally replaced. They persist. They are in parallel to each other. They still coexist. There will be, you will see one patient who has had the most modern treatment. The next one will be who has just finished his fish therapy from Hyderabad and coming see you. And there will be another person who has been on Ayurveda treatment. All these type of encounters with different patients can occur in the same day. So the diversity is not in the color, not in the foods, but also there's a huge diversity in the management of asthma and allergies. And this, I don't want to spend too much time on this, but it's just to tell you that such things are still going on in spite of all the progress that we are making, all the research we are doing, with all the new introductions of pharma medications, including biologicals. These therapies are still being continued. The fish therapy, I heard that on one, depending on the moon, I think it's the lunar calendar or something. This is run by these Goud brothers in Hyderabad. Almost 100,000 people line up, maybe more. And I have seen one or two of those patients too. And there's not just one-day treatment with the live fish. They also go on some dietary management. They go for follow-ups and all that. And the same slide here to show you the diversity, including Ayurveda, yoga. Each one has its own pluses and each one has its own minuses. And these are all new drugs, and there are some old, very, very old drugs along with it. So they seem to be sort of being available around the same time. So these are all challenges for us. And there are lots of combinations of medications in India. Usually, if you go to Western countries, it is single drug medication, single drug pharmacotherapy is very, very common in the US and UK and all. But here in India, it is sort of combination, like 2-3 medications in one formulation, 2-3 different types. It could be bronchodilator, it could be like a steroid, it could be an antihistamine, or it could be like an anti-leukotriene, all combined with one, and which makes it convenient for the patient, but very, very confusing for the medical personnel, because you don't know which one is working, what dosage is the right dosage, and what type of side effects is due to which component. So all these things are there. So ideally speaking, that is not a good idea, but it's still there. Very, very common to use combination medications, not just for allergy and asthma, but for hypertension and several other conditions. So I just told you India has changed and it is still changing. And it has got one of the highest burdens of air pollution in the world, one of the highest burdens. And I think I read somewhere where they named about 20 different cities across the world with very high pollution. 14 of them were from India. So it has got a major air pollution problem, and that has definitely has a significant impact on the type of diseases that we are talking today, that is allergy, asthma, and COPD, are directly related to these PM 2.5 levels, as well as all the other pollutants, the gases that you come up with. And Dr. Salvi, Sandeep Salvi from Chest Research Foundation, now it's a different setup. He published an article a few years ago, in the Asia Pacific. He was looking at basically the type of treatment, type of evaluation for asthma in India, and they were comparing several different Asian countries in that study, and India has one of the lowest scores for asthma management. And the common triggers were pollen, the pollution, the dust, and molds. And the problem with medication, if you look at it, is instead of inhaled steroids by the inhaled route, it was the oral steroids that were prescribed more often. There was like the average course for a moderately severe asthmatic was 10 to 11 times per year of oral steroid courses. So oral steroids have been still being used very, very commonly. And this is a very bothersome thing. Although we have excellent inhaled steroid preparations available, oral steroids are still being used. I'm talking about general practitioners who are the first line of treatment. First line approach is the general practitioners. Very few people go to specialists. It is GPs who see maximum number of patients. And there is very little insurance coverage for medical, especially outpatient care in India. Just even for inpatient care also, now it's slowly changing for inpatient care. But it is sort of very bothersome to see that 70% of the population have to pay out of pocket for medical expenses. And medical expenses have taken an astronomical rise in the last 2 decades. My father was a general physician, and he was a private practice in general, in Mysore, and he was one of the very, very popular doctors. There were only 4 allopathic doctors in Mysore at that time, and he would see 80 to 100 patients or more every day. The average charge for them was like 5 rupees or 3 rupees per patient. Now it is unbelievably high. So it is not uncommon to have people to spend a couple of lakhs per hospitalization. And it is not uncommon. Some people will also go bankrupt because of this type of huge expense for medical care. So it's called medical bankruptcies. Very unfortunate, but this has to change. If you look at asthma, it is, we have about 300 million asthmatic across the globe. About 38 million asthmatics are in India. The difference between asthma in India and asthma outside, asthma is much, much more severe. The prevalence could be low, but the severity of the asthma is very high. The disease burden is extremely high because of lack of education, lack of consistent care, lack of prophylactic care, as well as another major issue is the type of air we are breathing every day. Very heavy pollution, and that makes the problem much worse. So if you look at the DALY, death and disability associated life years, which is a measure of disease burden. It is Indian asthmatic in India has 2.5 times fold, 2.5 times more DALY than the global average. So it's much, much severe disease in India. And it is unfortunately more prevalent in poorer states. And it is also known that poor people smoke more than very rich people, and they smoke BD, and their living conditions where they live, they are exposed to a lot more pollution. They are living very, very high traffic area. We also know living within 50 to 100 yards from heavy vehicular traffic has a definite adverse effect on the causation of allergies and asthma. And if you look at the severe asthma, the number of people with severe asthma, as I told you, is high, and that is true for pediatric patients too. Pediatric patients have a very high incidence of severe asthma in India. And it is also has been shown that, especially this was a study done in Chandigarh, cigarette smoke, anybody smoking inside the house, the people coming from the households where their elders or parents are smoking, they have a much higher incidence of asthma in those households. And the low compliance rate is there, 68%. Economically, the burden is extremely high, almost 7 to 10 billion US dollars in India itself. But if you look at the medications, the pharmas have done a pretty decent job in offering really good medications in India. But the problem is the health professionals are not very familiar with how to use it. The general practitioners are still afraid to use inhalers. And if you ask the average general doctor and ask them to demonstrate how to use an inhaler, it has been shown 75 to 80% of them will make a mistake or doing it erroneously. So people do not know how to use the medicines right. If the health professionals themselves do not know, you can imagine a lot of patients cannot know properly how to use inhalers. So the educational part of pharmacotherapy is extremely lacking. And that is one of the main reasons why we are busy doing these awareness camps, increasing the awareness of the problem, increasing the knowledge of medicines, when to take what, when to take medicines, when to stop it, how to take it. All these things have to be taught to the public as well as to the patients and definitely to the health professionals. And for the first time, we are also having, for the last 15 years, formal training programs for the doctors. And because of that, the care of these patients definitely has improved. And that is based upon the survey we did. I think I have a slide on that. I'll show you later. So if you take the essential asthma medication, is it approved to be by the government to be offered to the needy at a subsidized or a free? That is not possible in India except 2 states. I think Rajasthan is one of them, I know, where they have legally, they have sort of giving it free. They have got free distributions of such essential medications. So let us look at some of the factors that can affect allergy and asthma pertaining to Indian conditions. So we do have 70% of our population living in rural area, but there is a huge shift of the population from the rural area to the urban area, as well as there is urbanization of the rural areas. So people who are living in the villages are not living the same lifestyle like before. Before they would walk a lot. Between villages, they would walk miles and miles. They would use bullock carts. And now it is two-wheelers. Some of them even have cars. The land value, since it has gone up, many of the villagers have become extremely rich. Because of this, their lifestyle has changed. They have become lazier. They sit a lot. They eat a lot. They don't move around as they used to before. So obesity also has set in the rural area. Lot, and allergy, asthma, hypertension, cancer, all those things have more increased now. And we will go through one by one, and I'll show you. This was a study we did in the rural area compared to urban children and the rural children several years ago. And this was between Mysore and the village of Vinoba, 40 miles away. And this was a collaborative study with National Jewish Hospital, University of Colorado, and the Brigham Hospital in Boston, and our center in Mysore. And was published in the annals. So to keep it simple, what we found during this study, the way people live is very, very distinctly different between rural and urban areas. Now, I told you it's changing now, but when we did the study, the distinctiveness was still very, very evident. Say like you come to America or you go to Europe and you go to a rural area, you will see these farms, you will see cattle and all that. That is true, that is different. But you enter anybody's house, the house that a person is living in rural America or rural Europe is very similar to almost similar to the type of house they live in the urban areas. They have the same wall-to-wall carpeting, they have sofa, they have TV, they have all the gadgets. Their kitchen looks the same, whether it is rural or urban. But not in India. India is very, very distinct. You go the rural areas, most of the people, when we went to this village of Vinoba, 90% of them were in these huts. These huts are made from the local material that is obtained within the vicinity of the lake, of the village. So their closeness to nature is extreme. They live with nature. They use the same material which is around them in the radius of 4 or 5 miles in building their dwellings. We call them huts. And they have mud walls, mud flooring. They have the shack roof. They put some different fibers and coconut, I don't know the exact material that they use for the roofing. So it leaks. So there's a lot of leakage. When it rains, it leaks. So there is a lot of mold growth in those places. And there is a huge amount of microbial exposure because of the cow dung they use to keep the flooring clean, which clean means away from the insects won't come, which is true, which it works. And they use biomass for cooking. They spend 4 to 5 hours cooking only. So the environment is very different from urban, where the dwelling is either brick and mortar, granite, and very rich people live in huge houses. They have separate bedrooms for these children and for each person. They have very, very little animal contact. There is no animals inside the house, except nowadays people have some cats and dogs, but not when we were there. Most of these animals, cats and dogs, were outside. Nobody has cattle now inside the house, or because the milk is available in the dairy farms. But when we were raising, we used to have milking cows in our houses every day. Nobody uses cow dung in the urban area. It is used only ceremonially. The biomass use is practically none. Maybe in a few houses I saw, they were using it to heat water for their bath in the bathroom. So the microbial load in the urban area is very, very low. Because of this, there is a distinct difference between the prevalence of allergy, prevalence of atopic sensitization, prevalence of asthma between these two places. The rural areas had very little atopic sensitization and a little asthma, and there was a huge correlation, very, very nice, significant correlation between the cow dung usage and the prevalence of asthma, which was based upon the ISAC questionnaire. In the urban locale, there was a lot more allergic sensitization, lot more asthma, a very little microbial exposure, and the I would say the figure was like in the range of 6 to 7 times more atopic sensitization, more asthma in the urban locale compared to rural locale. And these were only 40 kilometers apart. And this is in the rural area. You can see this cow dung and the lady cow dung cakes being dried up, and the lady is sort of um, uh, spreading the cow dung solution on the floor. This is to keep the insects away, which it does work. And this is a storage of the cow dung, and this is a tree on which this cow dung is being pasted and dried up. And that's not too far from my house. And this is from the city too, that tree. And this is a rural family bedroom, kitchen, living room, cow scatter, all in one place, a most hypoallergenic place that you can ever find. Here you have very, very close animal contact, lot of microbial exposure. Breastfeeding is happening there exclusive with the mom. So this exposure of high microbial exposure, as well as all the so-called dirt, is good for the immune system maturation, and it goes towards the Th1 pathway, not the Th2 pathway. So that is the distinct difference between rural and urban. Unfortunately, it is slowly changing now. Urbanization is creeping into the rural area. So another 20 years, it will be like very much similar to the city life as well as city diseases. So if you look at the type of air we breathe, Delhi, it is, I just read a few days ago as one of the worst pollutant air, that was polluted air people had to breathe. Because of the winter, there is a lot of inversion, and the air stagnates, and a lot of vehicles are moving around, like as you see in the picture down below, which is a common picture in every metro in India. This is the scenario, and majority of these vehicles are diesel vehicle. They use diesel fuel, which is really a bad thing as far as allergies go, because diesel exhaust particles are the ones that potentiate allergic inflammation. They act as adjuvant, they act as catalysts for allergic inflammation. So people who are already prone for allergies, or people who have just started having allergy symptoms, they very rapidly, their allergy reaction will progress, or the disease progresses, and they become asthmatics. If you have already got asthma, then your asthma gets much worse. So that is the vicious cycle that is happening in the cities. And these are all the pollens that are there year round. India being a tropical country, there's some pollen there all across the year, but definitely has these the pollen count or pollen calendar shows higher pollen counts during spring and fall, more trees and grasses and all that. We cannot go through it, but such type of information, pollen calendars, are available not throughout India, but certain places. But it is better than many other countries, but still a lot to be desired. And this is the usage of biomass in the rural area, where the exposure to particulate matter is extremely high. And the PM there, the exposure, they have written 1142 micrograms per cubic millimeter. I think I remember it should be the permissible limit was only like 10 or less. So this is like 100 times more exposure. So this type of exposure on a regular basis, where this lady is cooking 4 to 5 hours a day just to cook the food, and the child is standing there looking at the mom breathing that type of air, both will get significant pulmonary problems. She will have COPD without smoking BD or cigarette. So it is non-smoker COPD in women is very common in the Indian rural household, and this child will get lower respiratory infection. The lung will not mature, and the lung functions will be abnormal throughout life, and will have definite pulmonary issues down the road. And this is a stove that has been shown. I had shown this in epidemiological talk. This is a stove which is made specially made stove, where because of the material they use, because of the aerodynamics of the stove, very little usage is enough of the firewood, and it uses 70 and produces very, very little smoke, 75% of smoke. Actually, I bought this stove. It is in my house, actually. This is our assistant using the stove there, cooking right there. And this can be a very, very good gift, Diwali gift for people. Instead of Diwali sweets or saris, you can give these stoves, which will actually make a difference in their respiratory health and overall cleanliness of the air inside the house. It is available in India, costs 1,200 rupees. So environmental tobacco smoke is a definite issue. And unfortunately, 97% of the parents smoke near their children. So there is a secondhand smoke definitely has an adverse effect on their own children. 13% of the Indian households have more than 2 to 3 or more smoking members. It is not uncommon to have the parents smoking, even grandparents smoking inside the house. Very, very few women in India smoke, 10%, but compared to US, it's much, much higher, 30-40%. Maternal smoking in India is very, very low, but because of the biomass, that has got a lot more damaging effect on the women's lungs than cigarette smoke or BD smoke. And you need to know that BD, the poor man cigarette, has a lot more nicotine, 7 times more addicting than the cigarette. And the PM values, when you burn the BD or the cigarette, or in the, it is the BD has a lot more particulate matter than the cigarette. Now, coming to dampness, a lot of Indian homes are damp because of the water leak, and dampness especially promotes mold growth. And if you have already an asthmatic child who is sensitized, for example, to alternaria mold, which is a mold which is outdoor and indoor, or other molds, the chances of him developing severe asthma is 8 times more compared to a child who does not have sensitization to molds. So sensitization to molds has a very, very adverse effect in the progression of asthma. And we also have lots of parasites. In one way, parasite is good for keeping the allergy level down. And that is probably one of the reasons why the village people who have got extensive exposure, infestation with parasites, have less allergies, because the immune system IgE production is directed towards the parasitic antigen rather than the allergenic antigen like pollens and molds and dust. But because of the cleanliness, because of the hygiene, because of this deworming, which is one of the huge programs the government is sort of going through, does it across the country, the number of people having parasites is becoming less and less. In one way, it is good. In another way, it is not good, in that the immune system now needs something to direct its IgE production, and that will be pollens and dust mites and cockroach. So the prevalence of allergies is going up as the prevalence of parasite infestation is coming down. Breastfeeding, I think, is an excellent thing. And fortunately for us, it is not uncommon for the Indian mothers to breastfeed their child for more, for months or sometimes years, especially rural households, maybe 2 to 3 years or much more. And you are the experts in it. You know a lot more about this than I do. And exclusive breastfeeding is very common. And so breastfeeding actually promotes oral tolerance. Oral tolerance doesn't mean only tolerating in the mouth. It actually means making the whole GI tract resistant to development of allergies. So it actually matures the GI tract better. So the prevalence of allergies in breastfed children is a lot less compared to non-breastfed children. But once the allergy has set, once the allergy has set in due to some other reasons, the breast milk protection is not very good, especially regarding asthma. BCG, every one of us have been vaccinated against TB, mandatory BCG vaccination by the government, which is very, very helpful to help us build up a resistance against TB. And TB, according to some researchers, seems to reduce the sensitization, seems to be protective against childhood wheezing, but there is some controversy here, so we do not have a final word about it. C-section is becoming more and more common in India, and obstetricians love it because they don't have to wake up at 3 o'clock in the morning to deliver a child, and their income also is much higher doing C-sections. And many women, especially in the urban area, like C-section because they don't have to go through labor pains. And the parents feel, oh, this is a lot easier. I just take her to the hospital and I'll get a kid tomorrow. But C-section has not a very good thing because it's against nature, especially if it's not indicated that you keep on doing C-section. It is not the smart way, especially allergy-wise. For immune function maturation, you need that microbial exposure. At the time of birth, it is very necessary. At the time of birth, the vaginal flora and amniotic fluid is ingested by the fetus, by the baby as he is coming through the delivery through the vaginal route. And that bacteria has a role in getting the immune system go towards the Th1 pathway. So it has been shown, especially in children who have born through C-section, especially in the first year or two, the chances of him developing allergic diseases is much higher, and it does not seem to have long-term side effects. There is a question whether this could cause some childhood obesity, and that could even cause some asthma. But in the short term, there seems to be an increased risk of allergy, atopy, eczema, asthma, like that. And traditional medicine is used in India. There's nothing wrong in it, but there is definitely, the problem is many times the practitioners who use traditional medicine also use allopathic medicine with very little knowledge, especially in the use of systemic steroids. We have seen several times where these practitioners are giving these powders which are got actually steroids, and telling them just give it every day, your child will be okay. And child will be okay as far as asthma goes, not with side effects. So it is not uncommon to have children who are stunted, who are Cushingoid, who have got hirsutism, all the side effects of steroids, because it is being given without any consideration by such practitioners. I'm not saying all of them do it, but there are some practitioners who do it. It is unfortunate. But if you look at traditional medicine per se, there are some good medicines in Ayurveda. And some of these are mentioned right here in the chart: ginger, Tylophora indica, Eucalyptal, Boswellia. I don't know a whole lot about them, but few things I know about it is one of them have got what they call as a steroid sparing effect. The way it does is works like ACTH. It stimulates the steroid production, but it does not have the side effects of the excessive steroids that are given. So it can stimulate steroid production, natural production is increased, but not replacing the natural steroid. You're not overdosing it. So that way you are getting the steroid effect without having the steroid side effects. Now let's look at some allergy. What happens due to allergic sensitization in India? In aeroallergen sensitization is definitely has increased in India over the years, both in children and in adults to some extent too. But if you look at foods, it has really is still very, very low. But sensitization means presence of IgE antibodies has increased even in the foods based upon the studies, but there is a question whether this could be false positive, which we are going to discuss a little bit later. But as far as the sensitization goes, it is on the increase both for inhalants as well as for foods. And this is showing that prevalence of allergic rhinitis, asthma, and atopic dermatitis compared to the developed countries are lower, but compared to other lower income countries or Asian countries, it is on the increase. It is overall, it is still low. Allergic rhinitis is definitely increasing in the teenage, and both exist in 70% of the patients. Majority of the reactions, sensitization is to dust mite, cockroach, and a few pollens, but dust mite, cockroach, alternaria molds are the three asthmogenic antigens. So we need to test for these three antigens using good extracts, good testing materials in every child who has come to you for allergy testing. The reason for that, it is not only important for diagnosis, but it is also important for prognosis. If you have a child with just allergic rhinitis and has a child with the dust mite reaction 8 by 8 millimeters or more, chances of that child developing asthma is extremely high. Compared to a child who has a negative reaction to dust mite and another child having a dust mite reaction which is 7 to 8 millimeters, the chances of the child developing asthma is 8 times more in child who has got dust mite sensitivity. So it is very, very important to use proper skin testing material for these three antigens. Unfortunately, most of the skin testing material available in India, manufactured by the local companies, do not come to the standard that we have in the developed countries. So many times we end up importing these three antigens and testing. And that is something we need to address later on. These three antigens cannot be compromised as far as testing goes, because we did a study at CMC Vellore looking at the difference in the dust mite sensitization among the patients using the standardized material from the United States and using three other indigenous preparations from India. And we found the Indian preparations were only 5 to 26% reactive compared to the standardized antigens from the US, which means that there is a possibility that you will be missing sensitization being diagnosed in 74 to 95% of the cases, which is a very bothersome thing. Atopic dermatitis, we don't see a whole lot in India compared to Australia, Europe, and America. And there are also some regional differences in India, quite low in North, in Kerala, Kottayam has got much higher. I'm not sure why, whether it is pickup rate is better there, I am not very sure why, whether it is related to the diet due to the weather, but it seems to have a definite regional differences. Genetically, there must be very similar, but the environment could be different. I'm not very sure there. But generally, filaggrin mutations occurs less in Asians compared to Europeans and Africans. Now, drug allergy is a lot to be desired. Drug allergy is present in every country, in every population you have drug allergy. But in India, what we have is we do not know, we do not have the proper material to test for drug allergies. There's a lot of lacunae in the knowledge of drug allergy evaluation. Just common testing for penicillin skin testing, you don't have the right material. So we need to really spend a lot more time in improving the situation, educating our peers about drug allergies. So not only lack of testing material, lack of awareness, lack of knowledge, as well as a huge deficit if reporting. So this needs a lot of work. And the same thing is true for insect allergy. Now, again, another neglected emergency, another condition is anaphylaxis. There is no data, there is no Indian data. There is very proper, there is suboptimal knowledge among anaphylaxis, just the diagnosis, how to pick up, what to do. It is not uncommon when somebody has an acute reaction. I have seen they are being given antihistamines like Avil and Efcorlin or some steroid is given, which do not help in anaphylaxis reactions. They take a couple of hours before they work, and the patient could be probably will recover on his own or he will die. And the only drug that seems to work for it is epinephrine or adrenaline. And this has to be stressed at every stage, at everybody, including not only medical people, health professionals, general public should know about it. And they should know about injectable epinephrine for is the only way to prevent adverse, unfortunate results due to anaphylaxis. And Asian children are genetically more prone for anaphylaxis. This has been shown in Australia, where the Indian parents who have settled there, their children, compared to the native Australians, the Asian children who are brought up in Australia are several times a higher risk of developing anaphylactic reactions, asthma, allergy, and all that, probably because of the genetic pattern and the environment they are also brought up. Insect allergy is another very major neglected area. There are many more stinging insects in Asia compared to other temperate climates, but there is practically no epidemiological data. There is some few here and there data, but not very consistent. No reliable testing materials are available. No treatment programs are available for proper immunotherapy. All of them have to be imported. And the materials that are available in the Western countries, we have fortunate enough that they are extremely effective. For Hymenoptera allergy like bee sting, wasp, yellow jacket and all, the efficacy of immunotherapy reaches almost 98%. So it is extremely effective. So such things have to be available to our patients as well as emergency epinephrine. There are many fatalities that are reported wrongly or underreported, or they are given different causes in their death certificates. They may be mislabeled as cardiac arrest, where the patient could have died because of the insect sting. So this is a major area that needs a lot of work. Food allergy is definitely has shown some improvement in the type of data we are collecting in India. And the major study was done. It was a Europroval study, which I have a few slides to show. And what that Europroval is a study of around almost like several developing countries, about 30 or 39 different countries were studied. And India was one of them. And the center that where it was done was our own center in Mysore. So Dr. Mahesh and his colleagues did a very excellent job and looked at this pediatric population, adult population, and the if the summary was there was very little allergy, very low prevalence of allergy. When I say allergy, clinical manifestations of allergic reaction after ingestion of food with a temporal relationship, that was very low, but very high degree of sensitization. That means the immunocap or whatever, it was very, very high. Was quite high, but allergy was low. So there's a huge discrepancy between the serum IgE test as well as skin testing. So this is something we need to talk more. That is, if you just do immunocap alone as a screen for food allergy, you are going to get a lot of false positives, because the Indian population's serum IgE normally itself is several times higher than the Western values. So we have a lot of high IgE values in India, which is normal. And that IgE is probably directed against parasites, or it could be directed against carbohydrate component of these antigens. So these are all false positives. So when you do immunocap, you can get false positive because of the high IgE itself. So never do immunocap screen for food allergy. If you want to do evaluation of foods, you need to get a good history. Based upon the history, you can do skin testing, use the actual food itself or the testing material that could be used. But I have several colleagues, even in the US, who do testing with actual food itself. If somebody says milk bothers me, egg bother me, they get that particular food and test with that particular food itself, and they will have another person as a control. It may look non-standardized, but the result is much more consistent and much more clinically, much more useful, and correlation is much better, because the testing material commercially available for foods is not very reliable, even in the United States, because of the changes that can happen due to storage. So this is the Europroval study, where a huge number of subjects were enrolled, and finally the number of patients who were just found allergic by history or by immunocap was very, very few. So this is just showing that the average Indian population IgE runs almost 450 to 500, whereas in the Western countries it's around 100 or 150 or sometimes less than 100, depending on the population. So this is showing there's a discrepancy between skin testing IgE, specific IgE. So the specific IgE can just be positive, whereas actual skin test may be much lower. So you are getting a lot of false positives with specific IgE. We generally don't use the word immunocap, because immunocap is a trade name. So we generally use the word specific IgE in vitro. If you look at this particular chart, and you use that any food, you just look at that, you see that the figure for India is 26.7, which shows that is a huge amount of sensitization, very high sensitization if you took to any food. So the prevalence of sensitization to foods in India is very high, based upon the determination of the specific IgE in vitro, not skin testing. So if you look at the allergy based upon their history, not oral challenge. So all these studies have limitations. The best way to diagnose food allergy is by direct oral challenge, which was done by the Health Nut study in Australia. So their data is much more reliable than this data. This data is based upon patients' words, the patient's history, that's all. And what it showed was the prevalence of allergy in the same group of children is only 0.11. So the sensitization is very high, but allergy is very low. So we just did a very preliminary food allergy survey in India recently, and found that among our own graduates from CMC as well as from Delhi responded to in their own patients. So this was a little bit of a skewed patients. These are all patients of allergy specialists, not general population. And what it showed was the number of people. The most common food allergens were egg, peanuts, and milk. 70% of the responded reported patients with anaphylaxis did not have a prior food allergy diagnosis. And almost 55% reported food allergy diagnosis was not confirmed by skin prick or skin immunoglobulin or the serum IgE determination. And 23% reported cases of anaphylaxis requiring emergency room care, and 43% reported injectable epinephrine that had not been previously prescribed. So basically what it showed was low rates of diagnostic testing in pediatric food allergy, and epinephrine prescription was also quite low for anaphylaxis prevention. So food allergy in that survey showed it was high during 10 to 16 years of age, and anaphylaxis was one of the most common presenting symptoms. 75% did not have access to epinephrine, and peanut and seafood allergies were significant in that group. And what these graphs are showing is food allergy keeps on changing based upon your age, 0 to 1, 5, 6 to 10, 10 to 16. As you get older, your reactions, your sensitivity to milk and eggs will start coming down. The peanuts and the seafoods start going up. In India, brinjal is one of those things that also seems to go up. So milk allergy is resolving by itself. By 16 years, 50% has less. Egg also reducing a little slower. Seafood started increasing quite a bit. By the age 10, it started increasing. Brinjal also increased. The wheat and the peanut here were stable and persistent. It's too preliminary. Looks interesting, but it is definitely showing some interesting pattern which has been shown in other studies also. So the current barriers to allergy and asthma is the education and training. We need India-specific scientific data and guidelines. We are in the process of collecting it. We lack aerobiological data across the country, but we do have excellent data in certain countries. But the calendars, we call it pollen calendars, are very old. They are like 15, 20 years old. And with all the construction that is going on, with all these disturbance in the fauna that you see across the country, where there is so much of digging and so much of different, so much of agricultural lands being acquired and the development happening, all these things have changed the aerobiological pattern of India. So we need some good aerobiological data. And we also have very huge number of patients who have got very poor asthma control. Severe asthma is very common in India. And we also lack certain appropriate diagnostics, like proper skin testing material is not available. Proper material is not available for allergy treatment like immunotherapy. And also there is a lack of access to medications due to socioeconomic reasons, lack of access due to knowledge, and lack of knowledge, as well as fear of specialists, fear of corporate hospitals, especially people belonging to the lower socioeconomic status. And in food allergy, there we need more rules to have better labeling. And because of all this, there are major challenges. Now, at least we are doing some training programs. We have trained almost 800 to 1,000 doctors in the field of allergy now. So things are looking a little bit better. There is some sort of an allergy specialist in any town now within 50 to 100 miles radius, which was not like that before. And the education is slowly getting better, but still it definitely, compared to other countries, it is lacking. And we do not have emergency epinephrine available yet in the self-injectable form. And research is improving, but still a lot to be desired. And in the healthcare organization, it is still not a recognized independent specialty. It is mainly practiced by organ-based specialists like ENT, pulmonary, like that. And there is nothing like a full-time allergy specialist. There is nothing like a DM in allergy where the teaching is only in allergy, immunology like that. We still lack that. Especially in the US, if you are a pediatrician, you want to go into allergy, then you go into fellowship, which is 2 to 3 years of just allergy immunology, only for 2-3 years every day. We don't have that type of training yet. And because of the public education is huge challenge, because we have too many languages and so many other languages, challenges in India is a very, very interesting country, at the same time, very difficult also. And there are lots of stigmas, there are a lot of myths and lot of stories. And all these things are all challenges for us. So if you look at the global challenge in the manpower, it used to be much, much worse before. We used to only have like estimated specialists were only 200 or 150. Now we are up to almost 1,000. But if you look at some of the other West developed countries, we are still way down, especially with the ratio, of allergies. The USA has a ratio of almost 20 allergies per 1 million population. India has 1 per million, which is much better than before, but we need to at least go up to 4 or 5, and that will make a difference. So some of the postgraduate training, DM none, fellowship yes, but still it is combined with other specialties like pulmonary, and diploma courses yes, and they're mostly are still distance learning, but definitely have shown an improvement in the care that is given based upon the surveys we have done. Online courses, so there's one in Bangalore, another small one, shorter one started. I don't know much about it, but the one I know that we started about a year ago is extremely going very well. CMAs are going, a lot of CMEs on allergy, asthma almost every week. Medical college curriculum is extremely limited. The number of amount of exposure the medical students have, for example, asthma is 1 lecture in 1 afternoon, that's it. And immunology, I'm not sure how much exposure they have, but still a lot to be desired. Medical students have to rotate in these clinics. Medical students have to come to these immunology clinics, and that is the only way they will learn working with specialists. And this is the program at CMC where the trainees are going through clinical exam, discussion, as well as skin testing, clinical exam, pulmonary functions, and all that they go through. And a lot of them, and this is the aerobiology tour to study the fauna. The aerobiologist, Dr. Agasha from Bangalore University is there. And these people are exposed now for the first time that there is so many things to learn from looking around than just looking at a tree and seeing, oh, beautiful it looks, but there's a lot more things you need to look at now. And we did a survey of our own graduates from CMC Vellore a few years ago, and the response rate was not bad, 28%. Survey Monkey was utilized, and summary was these doctors responded that the asthma allergy practice overall for diagnosis improvement had improved. 85% of them showed definite improvement. Confidence in disease management and improvement, 66%, and achieving the set goals of the alumni, what they wanted to achieve before they came into the program, after they passed out and practicing, it's about 95%. So overall improvement score was 79% after the diploma course, which is fairly quite impressive. So the future for allergy asthma care in Indian subcontinent, rest of the world is very much interested in us to know why are we having so little allergy compared to their countries. So we must be doing something right. Something right we are doing right from the beginning with our rating our children, the feeding, the food habits, the introduction of buttermilk, yogurt, all these types of different foods which influence the microbiota from very early age group. So all these things are extremely interesting. Animal contact, usage of your cow dung in the village is very, very interesting for the people around the world, and we take it for granted. And we always blame, there was so much of dirt and all that. But I saw a book written by a Westerner that it was like a 500-page book. 300 pages were all references, 200 was the text, and his title was Dirt is Good. And it was that is the title of the book, and it was very, very interesting reading. A medical, social, political, academic revolution she will be happening soon in India. And I'm sure next 20 years will be a revolutionary thing for the specialty of allergy, asthma, and immunology. And thank you very much. And this is the group that we work, International Asthma Services. This was an award ceremony one night for us. And these are all the stalwarts in the profession in the University of Colorado, most of them at National Jewish, as well as a few have come from out of state. And we honored Dr. Nelson with a shawl. You know, they were all excited. Dr. Kirkpatrick is in the shawl, myself and all that. So I just wanted to share this interesting picture with you. Thank you very much.
So thank you very much. Yes.
Did I exceed the time a lot or what? I don't know.
Not a lot, but I think it was very worthwhile. Thank you so much, PK, for that insightful talk into status of allergy in India and so many other aspects which you focused on. And then especially on the training component and development of the specialty in India, which is also a very, very important aspect of this particular discussion. So we have some questions, and I just had to set a ball rolling. Since you just mentioned about dirt is good, do you also conform to the hypothesis, the hygiene hypothesis, or you didn't talk about that at all in your, and many of these things like animals in the house having endotoxin or, you know, overcrowding, worm infestation, whether all that helps in preventing the allergy in India?
Yes, I do. I addressed it to some extent in the epidemiology talk.
Yes.
And that's why I did not want to repeat much of it today. And, you know, to me, I don't think it should be called hypothesis anymore. There is so much evidence to support. Yes, there's so much of evidence to support in saying that microbial exposure during the window period, which starts just in pregnancy itself, from the second trimester of pregnancy and up till maybe the child is born until the 2 years of age. Some people even say up till 4 years. The exposure to microbes seems to have some definite role. Microbes not only in the form of animals, it could be in the form of you know, the type of food that we eat, and also the type of lifestyle that we have. All these things have a role. And because of the microbial exposure playing such a role, instead of having patients, families using cow dung and all that, we tell them to get a dog now. We tell them to get a dog. And dog is full of microbes. Having a dog inside the house during pregnancy, during child rearing, has some role now to promote this Th1 pathway to some extent. And the other issue is the traffic issue in India is another major issue, which has got deleterious effect on the whatever good we are doing on one hand, we are undoing it on the other hand by these pollutants. So air pollution in India has a major adverse effect on the respiratory scenario.
Thank you. There's a question about cesarean section. Dr. Amit wants to know what's the exact relationship between cesarean section and asthma. Because
which one? Between what?
Between cesarean section, having the baby being born by cesarean section and then developing asthma later on. Is it seen in non-allergic mothers also? Because in
Okay,
an
this
allergic
cesarean,
mother, of course, there is a predisposition for the child to develop asthma. So,
cesarean section data is, I would say, to some extent, it is sketchy. It is not absolutely convincing to everyone. But there is some suggestion to say that cesarean section babies, there's a higher incidence of atopic sensitization asthma, especially in the first few years of life, not later on in life, maybe in the first 3 to 4 years of life. And they ascribe it to the lack of microbial exposure during the time of birth, because of the child is just is void, is sort of devoid of the vaginal route and the with the bacteria that they are exposed in the vaginal route as well as in the amniotic fluid. That initial exposure has a major role, that is what they say, yes, in the development of the immunological maturation. So one of the things that has also been shown in, is they have shown that the they have shown it in several ways. Just the saliva also plays a role in promoting this microbial exposure. And they have done some studies where when they were feeding the child, the nipple, the bottle nipple, they would in one group, the nipple would be first put it into the mom's mouth, and then the nipple would be used. Other one would be used straight like that. So the nipple that was used initially by the mom and then used by the child, that group developed less sensitization compared to the other group. So all this type, it's sort of very looks interesting, but I don't know exactly whether that made any major impact, but sort of makes you wonder. They say maybe it is due to all that microbial flora in in the saliva that is protective and all that. So there are a lot of such things that are there when you are talking about microbial exposure. But cesarean section data is there to some extent interesting, I would say. It is not 100% convincing.
there are some prospective studies on use of fish oil in preventing asthma in the mother, and like omega-3 fatty acids. Hans Biscard's group from the COPSEC study in Copenhagen, they have mentioned that that's a factor which really modifies the allergic response later on. What do you think about that?
I think with more of an antioxidant effect,
Okay.
more protection, especially fish and fresh fruits and all that have some protection against the pollution more than, and that way it might be helpful in improving the respiratory health rather than directly affecting the IgE mechanism or the allergic mechanism.
Okay. Dr. Siddharth has a question, and I think we'll keep that as the last question, which is considering the association between smoking and asthma, what is your take on ACO, that is asthma COPD overlap, as a separate clinical entity, especially in adults actually?
Asthma COPD overlap syndrome is very common, especially in India, because of the type of care. There is very, very irregular care given, and these patients, and we know that people who have got asthma, because of the care that is not given, they develop COPD, and people who are prone for atopic tendency with COPD can develop asthma. So that combination we see very, very commonly in India. Very commonly we see the overlap syndrome, and these people have a fairly stormy course
Right.
compared to the other ones. So yes, it is definitely conducive. The type of conditions that you have in India conducive for overlap syndrome.
So thank you, PK, for a wonderful talk and very insightful observations. We have some more questions, but maybe once we have this talk again, webcast, we can address those questions again. Thank you
Sure.
very much for your time
Welcome.
and for your consideration. Thank you. Thank you.